Welcome back to another episode of the Dr. Mollie James Show. Today, I'm honored to have guest Dr. Brenden Cochran with us. He is a naturopathic physician. He is a physician educator and an expert in many fields in IV nutrition, ozone, and today we're going to talk about one of my favorite topics, which is EBOO. This is something that's gained wide notoriety on social media, and we wanted to set the record straight on some things we're seeing that are going off the rails. So, Dr. Cochran, welcome to the show.
Thank you for having me.
Yeah, very good. So I learned about EBOO long before COVID, and I was fortunate enough to come to the Ozone Conference and get the Stratus EBOO system and get plugged in with you. And I've learned a lot from you. So I think the audience will do the same. Give them a little bit of basics on what EBOO is and kind of where that came from.
Yeah, so EBOO actually started around 1993. Dr. Bochi and a guy named Dr. Nicola were experimenting with it, specifically more for terminal cancer patients. They were looking at its use. So Nicola's more nephrology, and Bochi's this big guy in the ozone community that he's really interested in the immune effects of ozone, I should say, and documenting. And he has several books out on it. So he's well known in the ozone community. So that's kind of the initial starting point of it. And what EBOO is then is it's basically ozone and oxygen, or you can just deliver oxygen alone. And it's a process that you're taking blood out of one side of the vein and you're returning it to another side of the body in another vein. And while that's happening, it's going through one specific dialyzing filter, and that's where the gases are exchanged. And there's lots of little filaments in there that are really, really sticky. And that continues to go on for roughly no more than an hour for a safe procedure. So that's the rough process of what EBOO is.
Now I'm gonna back up 1 second for anyone who's just learning about it and they've heard the term. It's extracorporeal blood oxygenation and ozonation. So some of us short term it with ozone dialysis. I don't know that I love that term, but it's a circuit that runs for about an hour.
Yeah, and I think the ozone dialysis is, I don't like that term either, because then it gets people confused that I'm getting dialysis, and it is not dialysis. Dialysis is much more complex with multiple different dialyzing filters that are used in the system. So I don't like that term. I agree with you. The other thing I'm kind of not liking as much, because we're on this discussion, is EBOO in general is like, what does that mean anymore? It's kind of like there's a nutritional IV out there called Myers, right? Dr. Myers created. And anytime a doctor ever refers somebody in to me or says, oh, I'm giving them a Myers, I'm like, what does that mean? Because
Right.
it really has so many differences, so many variety in it. And EBOO's turning into the same thing. We're seeing that there's so many differences in machines, so many ways of delivering it, so many concentrations that I think we're going to get into that really makes it so when you hear EBOO, understand they're not all the same.
Yeah. And we have patients all over the country, and I always cringe when they're like, oh, there's a place nearby me that does EBOO. Cause I'm like, yeah, but what does that look like? And what machine do they have? And who did they train with? And, we can't guarantee consistency in the product. So, and one of the most irritating things right now with the ozone dialysis is the blood oil change. That isn't I mean, that to me is super gimmicky and it cheapens this. This is a really serious treatment that can hurt people if it's done incorrectly. And so that's why I wanted to kind of bring you on and set the record straight. Like, what does that look like? And these people that are holding out these giant buckets of like, look what the crap they got out of my blood. I'm like, that's not quite it. So tell people a
Yeah.
little about ozone, what it is, kind of powerful oxygen molecule. So tell them a little bit about how we make ozone and then what that does in our bloodstream.
Yeah. So a lot of people, when they think of ozone, if they've never been around it, they think it's a toxic substance. And my argument would be anything that we use, even nutritionally, like water, can be a toxic substance depending on the dosage we're using. But the specific dose that we use can also be therapeutic if used appropriately. So what ozone is it's simply oxygen. It's three oxygen molecules instead of what you breathe normally, which is two oxygen molecules. So we make that in the environment. It happens naturally. You see a lightning storm, we make ozone. You smell it in the air. So that happens. And if we get too much of it in large concentrations and we breathe it in, our lungs are not strong enough to buffer the oxidation of that, and it creates harm. But if we have small amounts of it and it encounters other parts of our body, it actually causes a balancing reaction in the body, which is good. It's just like when you push yourself to exercise, when you're conditioning yourself, that's a healthy thing to do. So we shouldn't be fearful of ozone at all. It's just, again, where is the dosage used? And here's the key thing I think that people miss and really irritates me is like medicine, when you go to the hospital or you go to acute care, everybody gets treated exactly the same with this condition. And I'll tell you, you know this, I know this. Everybody that comes in that has a condition that's chronic, every chronic condition is different from person to person to person. There are similarities, but there's a lot of differences. And this treatment modality with ozone and with EBOO has to be personalized for that individual in front of them. Otherwise, we may not get the results. We may cause harm. And so we have to understand those dynamics. Now, ozone, we make it with a machine. Instead of the environment making it, we take an oxygen tank and we run it through a machine that creates the electricity like a lightning storm. And it produces a small amount of ozone that comes out of that gas. It's very low, actually. It's less than 5%. Most of that gas is actually just the oxygen we talked about that comes out. And so that's the process that we do that. And since it is an oxidant, and it can be a strong oxidant when given, especially at higher dosages or concentrations, we need to be really, really careful that the machine you're using has really high quality, because ozone has a tendency to want to oxidize or react with certain materials in the process of utilizing machine. And if we have that going on a machine, we don't want it reacting with materials, because I don't know about you, but I don't want that going in my body.
Right. So like the plastics and things that it goes through on the tubing, it can react and break those down. So you have to have really high quality resistant to ozone to use it.
Correct.
Yeah. And
Yeah,
not a
exactly. So the quality of the machine, they have to have high quality tubing. The kind of reactor where the lightning storm happens with the electricity, that has to be a very high quality, either quartz glass or type of stainless steel, which is non-reactive to ozone, or ceramics. So a lot of thought goes into that to make sure that the ozone's not reacting with the materials and then carrying that into the patient or the
Mhm.
person.
Yeah. So let's talk about first, because this is 3 or 4 treatments in one, in my opinion. So the first thing you have is the filter. So can you talk about what the filter traps, or what has been proven, or what we theorize that it traps?
Yeah, so the dialyzer, and there are different varieties again that are out there. The one that you should be getting is called a CTA Rennick 1500. It's a cellulose triacetate filter. If you see anything else up there, it's not as ozone resistant. You're more likely going to have breakdown products shooting into your body. Just like we talked about, you need ozone resistant materials. That specific filter has material which is ozone resistant, and in there, there's basically these little straws or filaments. There's about over 1,000 of them in there, and they have these tiny little holes in them. And when your blood passes through that, these little holes allow passive diffusion of ozone and oxygen into the bloodstream. Now, think of these little tiny little spicule straws. They're also really sticky. So when your blood passes through them, things can stick to the sides of them as well. So, what we do know that works for this specific dialyzer, if you go to the manufacturer website, and this is not a manufacturer that just makes these dialyzers, they make medical equipment all over the world. Needles that commonly you get poked with, they make those as well. But this is just one dialyzer in a dialysis procedure, one of many of them. And its role is to reduce beta 2 microglobulin which is a substance in our body that is inflammatory, creates inflammation. So we don't want it. We see it really high in certain types of blood cell cancers. We see it really high and we can track it. But period, you don't want a lot of it. So we know the manufacturer, if you go to their website, it says this is the delineation. Here's the studies that have been done on that. So we can clearly see that's being reduced. The other things they do talk about on there is minimal, but some loss of urea and electrolytes and stuff in that dialyzing process. And that pertains to why the safety parameters of making sure we're not getting multiple EBOOs in a week or getting a very long EBOO session, because we don't want to happen to have some shifts in your electrolytes or in your blood cell count. So those are the things that are like proven, it's made for out there on the market. And then the other things I think we're going to get into is we're learning more about.
Mhm. Yeah. One of the things that they presented at the conference, and I'd stepped out, but we think maybe spike protein or the breakdowns of spike protein potentially can be caught up in that. I know we've discussed before theoretically maybe mycotoxins, biofilm, cellular debris. There are other things that we theorize, and some of it's been researched or looked at, and some of it still needs to be done.
Correct. Yeah, most of the stuff with the microplastics, we don't have actually human clinical trials. That's on a industrial extrapolation. And the reason that was done with water is the product instead of blood. And the whole reason it was done is to make sure that, hey, we're doing this process. We want to make sure we're not increasing the patient's microplastic load, right? Microplastics are all the rave right now, right? Everybody's like, oh my gosh, microplastics are everywhere. So
Yes.
worst thing would be doing is you're getting a procedure and then you're giving more microplastics to the patient. So that was the whole premise from it. And what came of it was like zero microplastics were at the end of it. So it gives us an idea that maybe once we start doing more trials in actual humans with blood, that we might be able to get a better idea of that. So it's kind of questionable, but possibility. The biofilms, the blood clots, that was actually done and confirmed by a CLIA approved lab out of Arizona on about 8 or 9 patients, where the dialyzer was sent into the lab. Their blood was collected before and after and sent into the lab and then analyzed, and they identified things. So we have this small kind of clinical case study of yeah, there's microorganisms, there's some blood clots, there's some biofilms in the material. So that's what we know from that so far. And then the other one that we're learning more about is it can help with metals, and that's more of a before and after treatment, and when paired appropriately with something called a chelator to help kind of move those things out of the tissues into the bloodstream. So it seems to help with that. And then finally, the new topic that's coming up is spike protein, and I think that's a controversial topic everywhere, but it's starting to gain more recognition of this is a problem since COVID. It is causing people to have illness and cancer and other immune issues that if it persists in the body. And that initial testing that I talked about with biofilms and blood clots, they were specifically looking for that and they couldn't find it from that lab. The exciting thing is we have a colleague in our field that presented that she was able to get that identified with a lab outside of the country. And it's promising that we have a tool that can capture those things. But I think when we make claims, we need to be gentle with these claims to our patients. Like, hey, that we have a small, clinical case study. We can't be saying, hey, we got these big research studies and
Right.
blabbing this all over social media. Like, oh, look at all this stuff that's coming out of you. And that's just out of line. And in my opinion, that's unprofessional. It's deceiving. It's harming the patient. That should not be allowed. And anything in medicine. I mean, yeah, that's not true medicine. That's sales pitches. And we need to be really careful with deceiving people about what is going on truthfully and what is not going on. And that's going on all over the place right now. They're like, oh, look at this foamy mess. Look at all these toxins coming out. It's total BS. Let's just
Yeah.
put it that way. We'll get into it more. So,
Well, and the reason I really wanted to talk about this is important. Number one, protecting patients. But number two, when you have disreputable people in the field, what's going to happen? We're already under fire,
yeah.
and medical boards and things are already trying to limit our opportunities to do this. And so when
Yep.
you have people out there going rogue and making false claims, it's going to put the heat on people who are reputable and limit our ability to help people. So that's why it's so important to get people out of the field that aren't doing it properly.
Yeah, and unfortunately, that happened overseas in Malaysia. There was a lot of bad players and a lot of bad things happen, and then the governmental board basically shut them all down. So the few that exist are kind of underground now, and it's sad that you have a therapeutic tool, and understand it is a tool. It's not a miracle fix. But used in a series with other tools, it's a great tool. But I agree with you as these bad players come out thinking that they're going to make a buck on it, and they're focused and usually these are the people that are only focused on the tool. And I've seen this in the years of the rise and kind of plateau or falling now of IV nutrition. When I
Mhm.
first started teaching IV nutrition, there wasn't a lot of people doing this. It was
Right.
like kind of these chronic illness clinics, and then it turned into like this party bar and nutrition thing for everyone. And it's like, okay, guys, this is a medical procedure. This is not just walking off the street and get hooked up, because there's risks associated with this. And what we've seen from that growth is because of those bad players, like you said, there has become more restrictions from the government, more cost to the consumer because of those restrictions, and less availability for people. And I agree with you. If we continue to make claims without justifying some level of basic medical research before we start saying these things, the
Mhm.
same exact thing will happen with ozone and EBOO.
Mhm. Yeah. So if you're a patient out there and you're looking for EBOO, I just heard about it on social media. I'm curious to do it. What are some things they should look for a reputable clinic to get started? Like,
So number one would be, there's a few machines out there. There's only one machine that has the stamp of approval from the American Academy of Ozone Therapy. That's important because there's an academy that, does certification testing for the practitioners, and the practitioners continuously get updates. If that practitioner knows nothing about that, or they have nothing in their description of I'm a fellow of this, that should probably put a red flag as they don't really know ozone. They're just trying to bring this in. The other thing is training and certification. Did they do something? Do they have some certificate showing completion of hours? Or is this something the company just came in and did like a 2-3 hour walkthrough of how to use the machine? I would avoid those places that have a 2-3 hour walkthrough, because they don't know how to manage safety and they don't know how to get results. So you're likely going to either be disappointed in your results and spend a lot of money, or you're going to have an adverse event that could potentially end up in the hospital for. Um, if there's no lab testing or no visit ahead of time, and they kind of just rush you in, I would definitely avoid those places, because that means they don't have your best interest for safety or results. It's just about getting you in the chair and doing a procedure and getting you out. It should be really about personalizing what is going on in your history, what are risk factors we need to be concerned about, and then screening for basic labs for safety before you're doing a procedure like that. Those are really, really important things to be looking for with your provider. Other thing you want to avoid is if they're spending a lot of time on social media talking about these massive, exorbitant claims of, look at all this crap coming out. And they have a volcano of foam coming out of their waste container. If they have a bunch of red, you know, blood in the waste container, that's harm. That's actually your blood lysing. That's not healthy toxins. That's your blood lysing. That's what that is. So you want to avoid those things. You also, like we talked about, what the dialyzer looks like. CTA 1500. If they don't use that dialyzer, run. That means they're using a form that's not ozone resistant. Uh, all of those things are things you should be checking your box for when you're going in. And if they don't have those things going on, that would definitely tell concern, in my opinion, for wanting to get an EBOO with that individual.
Yeah. One of the things when we introduced this, and for people out there, it's probably a $30,000 to $40,000 investment to bring it into your practice. And so we made the investment, we brought it in, and I said, we're not going to be an EBOO dealer. Like, they need to be a patient of ours, and we're going to use, just like you said, we're going to use it as a tool to help them get results. It's not, the procedure is not the end product that we're trying to deliver. And the team was pretty taken aback at that after we invested that money, that we're not just out there trying to sell procedures to people. So I think
Yeah.
that's the other thing when people call in and they're like, well, I have Lyme and I want to do this. It's like, well, you need to have a consult with us. We need to see what you're doing for that before,
Yeah.
because you may not be ready for that, or that may not be appropriate for you right now. So,
Yeah. Yeah, that's a huge point that you heard me and multiple doctors always hear me ramp on is it's just a tool. It's no different than a screwdriver or a hammer.
mhm,
So if the clinician is skilled in how to place that tool in a treatment formula of other things you're doing,
yeah,
your results and outcome are going to be much better. If you just come in and you say, I have this condition, I just want to do EBOO, you're going to get mixed results because your terrain may be ready for EBOO. Your terrain may not be ready for EBOO. You may not be on a good protocol. You may not be doing things that improve the outcomes of what EBOO is removing from your system. So you may be wasting your money. And even though it sounds really cool on paper, uh, any of these things that come out, they always initially sound awesome, and they are
mhm,
when used appropriately in a formula. But when they come out initially and it's just them alone, they don't. I mean, stem cells the same thing. It came out, years ago. Everybody was on that bandwagon. It was like some of these clinics were like basically a fast food restaurant where you come in, get your shot, leave, spend, $10,000, $15,000 or more, leave, and then you wouldn't get any results at all. And the same thing happens with IVs. The same thing happens with hormone replacement therapy. Same thing happens with ozone and EBOO. And I think that that's really, really important. If you want results, you need to find a partner to work with you and assimilate that in a plan
mhm,
versus just going through and doing a tool over and over again. Otherwise, you get these claims like I've already seen it online and the practitioners asking, hey, I've heard from people that they're not getting good results with EBOO. What type of system are they using? And
mhm,
do they have proper training on how to integrate it in there? Otherwise, they're not going to get the results and you're going to be disappointed.
mhm. Yeah. So let's start with the people who may want to come in, they feel good, they're pretty healthy, they just want to do it for wellness.
Hmm?
Does that have a role and an indication?
I believe it does. I mean, preliminary things I'm doing and looking at people is like in the cardiac sector, and then their blood markers for inflammation is kind
Mhm,
of a big passion of mine. I also and these are people that, they're aging and they just want to make sure they don't have some surprise happen, right? I, I find that it does help control those inflammatory markers quite well. I also find that there's no other, I mean, giving oxygen to the body is an amazing thing because as we get older, our body gets poorer and poorer at assimilating oxygen into our tissues. And the other big thing with ozone that we need to realize, it is a preconditioning tool. So it increases something called AMPK, which increases mitochondrial and healthy cell function. It
mhm,
upregulates NAD, which is all the rave about trying to replace NAD. But isn't it better to train your body how to be more efficient at producing NAD than just replacing it? It upregulates all of your antioxidants like glutathione, which most people need to know. Glutathione is like the second most common molecule in your body behind water. And so we need to train our bodies to produce glutathione, not just replace it, but produce it. So the way I look at ozone and EBOO specifically is a great delivery and a very, if done appropriately, a very efficient way to do that. So you're not having to come in multiple times, and a very safe way and a very comfortable way of doing it with appropriate dosing to help increase all of those things. So a little bit more on ozone and why kind of I think it helps as we age. So imagine what you do when you go to the gym. When you go to the gym and you work out, you're working out your cardiac function, you're working out your muscles. So they're getting more efficient at things, right? Efficient pump and efficiency of more energy production, better glucose utilization in your muscles, better oxygen utilization. The same thing happens with ozone. Put a tiny bit, appropriate dose of oxidative stress in the system, and it trains the body to upregulate your antioxidants and several of these different enzymes that become more efficient. If we do that appropriately, it's a really, really good thing to precondition you from disease as
Mhm.
you age. If we do that inappropriately, where we give you a really high dose, because for some reason, North America, we think more is better. And if I'm not getting a lot of ozone, I'm not doing it right.
Mhm.
If you give you a really high dose, you actually exceed the body's ability to buffer that oxidant, and it actually causes harm. And I would say the high dose ozone, if you're doing that from the start, it's no different than you doing radiation and chemotherapy. And most of the audience knows how toxic that is to the body. The
Okay.
same thing can happen if you do high dose ozone right away, inappropriately, and not being preconditioned up to that or being used in a situation which is appropriate for that to be used.
Yeah. One of the things we've started doing as we stack things, I usually do an NIH before the EBOO, a smaller dose of ozone just to test and see how do they feel with it. Do they have a big reaction to it? Is that something you would advocate for? Is that part of how you do it? Or,
If they've never had ozone, that's a simple way to use it. The other way I typically do, if they've never had ozone, labs are safe, their history's safe, is I'll typically only give 5 minutes of
Mhm.
the lowest dose, like 3.5 microgram or concentration, I should say, on the machine itself. And the rest of the time it's just oxygen. And the reason I do that is that concentration of 3.5 or 5 minutes is equivalent to what they're getting with an MH. Now, if a patient comes into my office and they're extremely sensitive to like everything, they have the typical mast cell histamine, I react to everything you give me.
Mhm.
I don't even use ozone the first time. It's literally just oxygen, and we're just running oxygen through the filter dialyzing process and seeing how they're doing. And that can be very powerful alone just doing that. And I know again, as a patient, we're anxious to get things moving and we think more is better because that's how we've been conditioned, but that's just not how physiology and our bodies work.
Mhm. I'm going to pivot for a minute off of that because as we're treating more integrative cancer patients, we've got people going in for the IVC. And it's kind of
Mhm.
the same thing. They're going in for these massive doses of IVC at places that are just your corner infusion, I call it the McDonald's infusion center. They don't know
Yeah.
what they're doing in cancer. They don't know how to test if they have oxidative stress or not, and they're not using it appropriately.
Mhm.
So, I usually tell people to look at how the bags are mixed. Have them call and say, "Hey, do you treat cancer patients?" And if they
Mhm.
say, "Absolutely, we do," that's one thing. But if they're like, "Sure, we can,"
Mhm.
that's a negative in my book.
Yeah. If you're treating cancer, you need to be an expert at it because it's a life and death situation. If you're working with a person who's kind of mediocre, that doesn't really fly well because you're risking your life for a wrong decision. Are they doing something that may reduce the efficacy of your conventional treatments that you're doing and they don't know that? Or like you said, are they over treating in an inappropriate situation? So an example of that, if you come in and you're too weak, and I call it a dysaerobic state. So you're really weak, you're losing weight, you're malnourished, and you're going through chemo. You come in, it's not appropriate to hit you with oxidative stress or high dose vitamin C at that point. That will actually put you in a hospital or even kill you if you do it inappropriately. And a well-trained, vetted physician who works in integrative oncology will be able to recognize that in your history, physical exam, and your labs, and be able to say, "Hey, this is not appropriate right now. We need to build you up first."
Mhm.
If a provider doesn't understand that, then like you said, they're kind of the McDonald's of IVs. They don't do that. And they automatically think, well, the buzz in oncology is put everybody on high dose vitamin C. And so they are basically treating everybody the same every single step of the way. And high dose vitamin C, it's a great therapy, but there are some cancers which it does not work very well. And it's not the first choice. There are some metabolically active cancers where you want to use a different strategy for them, not just IVC all the time. So I agree with you. It's if they don't treat cancer a lot and they haven't gone through extra trainings and they understand this more metabolic terrain approach to cancer, and I wouldn't work with them. I would find somebody else.
Mhm.
And the other thing is, we're in the world now where that provider may want to learn how to do that and they're not there yet, and they may consult somebody else. I do that commonly with several other physicians around the world. Is they have a tough oncology case, there's no integrative oncologist around them except for this person, and they'll reach out and they'll say, hey, I need some help on this case because I know nothing about you know this oncology other than X, Y, and Z. And if they're doing that, they're working with another person out there or expert. That is appropriate because at least they have somebody who knows what they're doing. But if you're going into the McDonald's, I would not do that.
Yeah. I was actually doing some recon for a patient the other day, and I saw their high C infusion, and it listed high C and all these B vitamins and amino acids, and I'm like, "I'm pretty sure it's not how you mix the high C infusion." So, be buyer
Yeah,
beware.
and that well, and that's another discussion. All IVCs are not the same. So is the clinic using vitamin C that's derived from corn?
Mhm.
Is one. There are different forms of vitamin C. There's non-corn forms, corn forms. Corn's obviously more inflammatory. There's also training on how they're using the nutrients, right? Are they storing it appropriately? Are they using product that's been expired for several weeks that's on the shelf? Are they cross contaminating your bag? That's a flag for me. Do they have appropriate steps for sterility in their mixing processes? Some states do require, like in my state, where we do testing in our mixing room to make sure there's nothing growing on the surfaces. That's also really important to see if they're doing something like that. And it's required because all of that, if you're a relatively healthy patient and you get something like a little bacteria or endotoxins, which is basically these toxins pooped out by the bacteria, you're going to feel like you have a flu or you're going to vomit after getting that. You're not going to feel good, right? For maybe 24 hours or so. But if you're really sick and sensitive, that's going to put you in the hospital. And you may be in the hospital for several weeks. So I agree. You really don't don't shortcut it. And the other thing is if you're going to a place and it's incredibly like cheap, it's cheap for a reason. They're probably reusing products. They're probably using really crappy, cheap bags, which leach plastics into your water more often. And they're probably pushing product, mixing sloppy. There's a reason it's usually that cheap. Or unfortunately, I'm going to say they're just an idiot in business and they're giving IVs away. And I've seen that a lot too, where I look at the doctor's bottom line and they don't even know it. And it's like, you're bleeding out a lot of money every month in that IV room because you're basically pricing for your cost of goods and they're losing a lot, not able to sustain long term. So they'll be out of business very quickly, actually.
Mhm. Yeah. So again, knowing that you have a very advanced practice, where do you see going back to that, where do you see that fitting in the best? How do you determine when somebody's ready for that, or what conditions do you kind of use that for? So if someone's out there saying, I don't know if I should do EBOO or not, or if that should even be part of my discussion, what are the things that you see that working best for?
I mean, the top things I've been using it for, and I integrate into my treatment formulas. I do integrate it into in oncology. It's one of many different infusions, so integrative oncology support. I do use it a lot with my patients who have a large degree of toxicity, whether it be metals, molds, or other solvents. I do find it's helpful. Again, alone as a tool, it doesn't do the trick because it's just treating the blood compartment, right? It's not addressing your fats and your lymphatics and all these other areas. So you still have to address those. I also see a lot of complex infectious issues happening where it's helpful. So, Lyme or other complicated infection processes, which just are not responding to your typical things. Or if you are using typical things, it complements them to move the needle faster.
Mhm.
And then finally, again, the biggest one I'm also interested in because unfortunately that kills a lot of us is strokes and heart attacks. Can we have an impact on reducing plaque formation and improving the endothelial lining, which is these cells that line your blood vessels? Can we make them function more properly so that you don't have these surprise strokes or heart attacks that develop as you get older? That I think is a really, really big area. And it makes sense because if you look at ozone, just in general, research on ozone, predominantly a lot of the research is on vascular circulatory issues. So
Mhm.
that is a really, really promising area. If you have any, gangrenous or poor perfusion in the legs or diabetic neuropathies, any of those areas, it should be something to consider in part of your treatment protocol.
Yeah. One of the things I'm going to divert to the business side of things for a minute here because there's a lot of people out there that are used to system medicine. They're used to their $15 copay. They're still learning about things like integrative medicine and concierge medicine and paying out of pocket.
Mhm.
And a lot of them have sticker shock when they come in and say, oh gosh, this is
Mm,
expensive. If you
yeah.
have somebody with, a cancering process or a complex infection, what do you think is a reasonable amount of money that they should be budgeting per month or per year to be treating that condition? Because I think people way underestimate this and then
Yeah.
they don't get it's just like doing it yourself. They don't get a good outcome and they end up paying more to get help. So, kind of what's the range on that?
Yeah, I mean, if you have a really complex person or cancer, that range could be 20 to 50,000 sometimes a month, depending on how much they could do.
Mhm.
It may be up in that range, but the average person, if they're doing kind of middle road, 10, maybe 20,000 in a month is appropriate, I think, to be budgeting for. I know it sucks. Chronic disease bankrupts a lot of people, and you see it with even when they have insurance. Unfortunately, when they have insurance, they're bankrupt by their health issues. So insurance is not the savior. It's basically your emergency. It's like if your car you crashed your car and you broke your car. That's the emergency, but it's not going to fix the tires. It's not going to give you the oil tune-ups. It's not going to fix the little things that go along. And I think if because of that expense and relatively speaking, if you were to go to the hospital system and use those drugs and it wasn't covered with your insurance, you're talking half a million sometimes per month or more
Yeah.
for some of these drugs that are out there. So this is relatively inexpensive. And put it in context also of visit costs. Most of your providers, you're spending so much time and you're actually addressing multiple illness complexities that are figuring out a solution focused issue so it doesn't keep coming back and you need to be taking things ongoing. The conventional system lacks that area of that type of management. And so what ends up happening is you get a very quick visit. You often are seeing multiple different doctors, so there's no communication, no synchronism, and it's only treating symptoms. So your cost actually skyrockets as you keep going to them because you're adding another med, another med, another med, another med until the system basically detonates, and now it's a really costly issue.
Yeah.
Uh, I think it is more cost effective to be proactive with your health, and if people are finding a provider when they're healthy and working with them then to prevent disease as much as possible is
Mhm.
the most cost effective strategy. Even if it does cost money, you should budget for this. It is the most important thing in your life, not that fancy car, not that TV, because if you don't have your health, you can't function. And all that money that you may be stored up is basically useless if you're sick and not functional at all. And so that is important. Your health is your priority. If you're healthy and you can function, you can always make that money back, right? If you're crippled and you can't do it, you can't make that money back. So that is a really, really important investment to have and not rely on your insurance, because your insurance doesn't really care about your health. You're just paying the insurance company for catastrophic issues.
Mhm.
And I think we're seeing more and more. I know in my practice, insurance is covering less and less and less and less. You're just paying them
Mhm.
for nothing anymore. And it's like most people are learning over time, their insurance doesn't do anything for them. It's only there if I need to be hospitalized. That's literally all it's doing.
That's an interesting takeaway that I wanna pull out there just for 1 second, is if you have a chronic health condition, you're gonna go bankrupt whether you use insurance or not, but the
Correct.
insurance-wise, you're still gonna be sick, and it's gonna be
Yeah.
hidden behind insurance, but you're still gonna pay at the end of the day because of that out-of-pocket and all of and the
Yep.
inflated cost to pay for all the administrators and things, so it'd be much better to spend the money on something that's actually has the potential to help you recover.
Yeah. And that's if if you're budgeting, if you're an individual who's budgeting for, your lifestyle, health should be in that budget. It shouldn't be just food, a new car, TV, all this stuff. Health should be part of that budget every month. You're stacking that aside for basically, I have something I need to work with this provider proactively, or
Right.
I have a catastrophic event and I need a reserve fund that I can dip into. If you don't do that, then the problem is like I said, it will eventually blow up and eventually you'll go bankrupt, even if you have insurance,
Mhm.
because you can't. The problem is when you get sick, you have copays and co-insurances that are massive. When you have these drugs that are $500,000 or more per month and you have 20% responsibility, you can't pay that. And eventually you get to a point also the insurance says, well, you can't pay the monthly premium, we're dropping you. And now you have to go on something else. So insurance does not save you. And I think this is the biggest thing that you and I as physicians wish is people come into us early. Don't try to jimmy rig this at home or try to work with your pharmacist to figure this out. You need a professional to do this. You don't want to do it yourself all the time. Do
Mhm.
it yourselfers usually cost a lot more money because they make a lot of mistakes.
Yeah. Yep, I see that all the time. I have one last question on the integrative cancer, and then we can wrap up. So
Mm.
one of the things that I'm relatively new to the integrative cancer space, but I was a surgeon, so I've been treating these cancers. I know the spiel in the system very well. I gave it for years. Um, but we have patients who are looking for this and more, and they want an integrative approach. Maybe they're doing some standard of care things, maybe they're doing some things with us. But they go to
Mhm.
their standard of care team that says, "Don't do anything, don't take any supplements."
Yeah.
And that's okay, but the patients feel really caught in the middle. Like, what do I believe from each team and how can they work together? How do you solve that in your practice?
Yeah, I mean, the one explanation I make is, those people you're seeing in the conventional industry, they are experts at chemotherapy and they are experts at surgery. They are not experts at managing the side effects of that. They're not experts at anything else, dietarily wise, supplemental wise. This makes the chemo more uh, resistant, doesn't work, it's contraindicated, and this you want to take because it improves the sensitivity. So this stuff is going to work better. They don't know that. All they look at is what is in the basic drug manual and possible interactions. Or the one that makes me laugh the most is patient goes in and they like catch their doctor on Google searching something and say, well, Google says you probably shouldn't take this. I'm like, oh, really? That's really scientific of you.
Mhm.
So my take on it is I explain to the patient, this is why I'm doing this. And if they do want the studies with it, I will provide that. But if somebody says, don't take any of this stuff, it can cause harm, I'll usually say, okay, well, here's the thing. They're an expert in this area. I'm an expert in this area. And if they're saying that, I would ask them, because I'm not aware of any studies, I would ask you to go to them and ask them to furnish a study that says this should not be taken at the same time of that.
Mhm.
Most of the time, I'd say 95% of the time, unfortunately, they don't know anything about it. And the best answer is say, just don't take it,
Mhm.
instead of saying, I don't know. You should refer to a person who knows. They usually say, no, that you shouldn't take that. That's dangerous.
Yeah.
And I think one of the most alarming things that I see in my practice over and over and over again that should also key you in is a lot of oncologists or oncology docs. I've seen them in my practice that come in looking for integrative care. So some of them eventually they turn to that when they get their own disease. Or the other thing that happens is I get a patient that comes in and it says, man, I have cancer. I've been with you for, 5, 6 years so far. We've had this thing stable, but my oncologist got cancer and they die before me. I'm like, well, that's not good. That means they don't know how to treat themselves. They're just following the standard model.
Yeah.
So that's a discussion I have. And then finally, the discussion I have is, if you have two options. You either don't tell them you're taking these things because you don't want to ruffle feathers. And unfortunately, what I see so often is they'll just say, yeah, I'm not taking any of that stuff, and unfortunately lie to the other provider, which I don't like,
Mhm.
until the end. And they say, oh my gosh, you're doing so much better. You're recovering faster. Your disease is stable. And then the patient will tell them, well, actually, I've been taking all that stuff. And then they'll kind of be shocked at the end, or they'll say nothing, is what I've seen. The
And then they
other
don't
option,
hear anymore. And then they don't wanna hear anymore. Just
or,
stop.
or they'll take credit for it. They'll say, this is amazing. I've never seen this before. It must be this chemo that we utilize. You just responded so well to it. Or the other situation is you don't want to be deceitful to the oncologist and you are transparent with them.
Mhm.
But if they don't like that and they're arguing with you every time instead of working with you, you need to fire that oncologist and find somebody that will work with you and is more open minded. Those are kind of the two ways
Yeah.
I perceive the way I want the patient to approach. And some oncologists are very open minded and they'll listen to you and they'll work with you. And then others are just very close minded. They don't have time to research anything. They just learn from the cookbook and that's all they stick to,
Yeah.
type of medicine.
Mhm. Yep, and then my most vulnerable patients, and I'm sure you have the situation too, are people in more rural, remote areas where they don't have a ton of options, and they're afraid if they don't go there, it's gonna be a multi-hour drive, and they can't access it. So, I've seen both, and it kills me because I used to, tell your doctor everything you're taking, be transparent, and to not have that openness because they're closed-minded is very frustrating.
It makes this extremely frustrating. But the outcomes we see with people doing both things together is tremendously improved compared to just doing standard of care alone.
Yeah.
And there are areas in the country that, like you said, are more closed minded, and then other areas that are more open minded. Unfortunately, in medicine, it's become more their belief system versus evidence based medicine.
Yeah. Well, Dr. Cochran, it has been an absolute pleasure talking to you today. We're kind of winding up the hour, so I'm sure people have learned as much in this hour as I have in the multiple times I've heard you talk and been in your courses. If you had one note or one last word to leave people on, again in the EBOO space, so if that's what we started with. Um,
Mhm.
what advice would you give them, a patient who's looking for this?
If you're looking into EBOO, I think it's a very, very powerful, important tool. However, do understand that it is a tool and you need to be doing other things along with it to get the best results. Make sure you're working with a person who has had really decent training, certification process, that understands the machine, understands the safety, and understands how to personalize this for your either complex illness or your proactive healthcare plan. If they're not willing to do that and you're not seeing that happen and there's red flags about them selling you exuberant claims and volcano foam and all this stuff out of the machine. That's not an appropriate provider, and that's just a McDonald's, unfortunately. And you're not going to get the results, and you're probably going to get harmed, actually.
Yeah. And the last thing, if people wanna learn more, where can they follow you? Where can they find you to learn more or come see you?
Yeah, so I have two different ways. My clinic is Interactive Health Clinic. I'm north of Seattle, and I do people in person, and then I do remote. If it is in a state that I'm not licensed with, I usually have to find a provider to kind of work with because they're your main provider. And then my consultation services that I do are through my website, which is Dr. or Dr. Brenden, Brenden, Cochran.com.
Perfect. Very good. Well, it's been an absolute pleasure. I appreciate you taking time to chat with us today, and we'll have you back with updates hopefully in the future. So,
Thank you for having me. Appreciate it.
yep. And thanks for tuning in. Make sure to hit the subscribe button and share this episode with somebody you think could benefit because, as always, we're censored. See you next time.